Friday, and welcome to MedHeads. This is Neil Versel, Health IT reporter for MedCity News. I am moderating today for just the third time ever, and hopefully it goes better than, as well as the first time and better than the second time that I've done it. I'm doing it today because we are talking meaningful use, which is right up my alley, specifically the future of meaningful use. And I'm joined today, I'm live in Chicago, so I am escaping the snowstorm that's hitting the East Coast. However, my two guests are right in the path of it, or will be in the next day or two. I'm joined by family physician from New Jersey, Dr. Linda Girgis, who is also a MedCitizens contributor. Welcome, Linda.
Thank you so much for having me today.
And also by someone right in the eye of in the bullseye of the storm, Dr. Peter Basch, who is, I believe, you're the CMIO of MedStar Health in the Washington-Baltimore area, and you are right now in Washington, D.C.
That's correct. In the eye of the storm, I'm actually the senior director for IT quality and safety, not the CMIO, but certainly in the eye of the storm of the blizzard.
Yeah, so he's already told us that it's possible he may be, if the power goes out, we may lose him, so just warning everybody ahead of time if that's what happens, it's a possibility. And I have a little bit of experience dealing with East Coast storms as a native of Maryland, so I just wanted to establish my cred there, although I now live in Chicago. And there was a story in the Washington Post yesterday saying how, written by an ex-Chicagoan who's married to another ex-Chicagoan, saying how people in D.C. are just so wimpy when it comes to dealing with snow, and Chicagoans are actually kind of smug, which is kind of true, I have to say. But anyway, we are not going to be talking about weather today. You can find that information pretty much anywhere else on the internet. We're going to be talking about the future of meaningful use. And this became an issue at the J.P. Morgan Healthcare Conference a couple weeks ago when Andy Slavitt, the acting administrator of CMS, put the focus away from the usual biotech and pharma and medical device companies that are normally there, and said that meaningful use is going to be replaced very soon by what he said is something better. He didn't give us a lot of clues, but you see the hashtag up here over my shoulder. We've been asking people for the last few days to tweet your ideas for something better using the hashtag something better. Hasn't really done much so far, but hopefully a reminder will get people tweeting right now. So give us your suggestions, serious or whatnot. But let's turn to the discussion now. And both of my guests have written about how meaningful use needs to change. The more significant one in terms of the platform for it is Peter, Dr. Basch, who co-authored a piece in Health Affairs last week, a day or two after Andy Slavitt made those remarks. And you said that meaningful use needs to change, and in some ways that represented a change in your own tune over the last couple of years.
Right. So slight correction. The piece was published in Health Affairs a day or two after Mr. Slavitt's comments, but it had been written about 2 months previously and had been undergoing editing.
But they did add a note at the beginning saying that.
Yes. So you're certainly correct. I have been a supporter of the concept of meaningful use based on the idea that it was clear to me, as many who were early adopters of health IT, that there is no magic in the use of computers and technology. It's a tool, it's an infrastructure, it's something that can be used in trained hands, somewhat differently based on specialty and setting of care, to at least potentially improve quality of communications, improve focus on quality and safety, and with a bunch of other conditions being met, lead to better outcomes. And the concept then was health IT used in a certain way. I won't use the word meaningful. The word I used to use prior to 2009 was optimal, had the potential of doing good. And I was a big supporter of the concept of a bill that at least got the concept that it's not just having a computer on the desktop, It's how you use it. Now, of course, as we all know, there's a disconnect between concept and how something is operationalized, and unfortunately, meaningful use got itself into trouble pretty early on, and in a much bigger way with the release of Stage 2. And in my mind, in the biggest way, when CMS announced with the Stage 3 final rule, this is the last rulemaking we will do, in a sense saying this is meaningful use Stage 3 or meaningful use forever.
Yeah.
Wouldn't care about it that much, except the macro legislation mandated that a component of meaningful use be a forever component of macro. So
Right, and MACRA is the doc fix legislation that passed last year, and it legislates that 25% of the MIPS score, that's the Medicare, I'm sorry, the
it's a merit
merit-based
incentive.
incentive payment system.
Yes,
25% of that score will be based on the meaningful use rules. Now,
exactly. So
Lynn, you wrote about, I'll bring you into the conversation in a moment. You wrote about earlier this year, or I'm sorry, last year, wrote you called the doc fix a Trojan horse that is going to make things a lot more difficult for physicians. But we'll get to that in a second. Peter, why don't you go ahead and finish your thought?
right. So my biggest concern was what started off in Stage 1 as something that many of us said thresholds are low, what we're being asked to do, many of us are doing anyway, we could live with. The problem is, as the thresholds got higher and the measures changed, it became very clear that this one size fits all, or what we call a one size fits none approach, was becoming increasingly problematic, increasingly burdensome. And if it would be written as a forever component of the merit-based incentive payment system, something that would be bound to get in the way of doctors doing what they should do, which is figure out how to individualize their use of technology to serve the best interests of their patients. So my position changed from reacting to and commenting on, can we make this measure move from 80% to 60%? That's a reactive mode to see what you could live with, to our patients deserve more. The potential for health IT is there. We need to completely reconceptualize the meaningful use program. We can't get rid of it without amending the macro legislation, which certainly is beyond what I think I'm capable of, but we can certainly, through regulation, do a better job. So that was the thrust of the piece that I wrote in Health Affairs about how to reconsider meaningful use, not just so that it's meaningful to doctors, but meaningful for our patients.
So, Linda, tell us why you think that meaningful use or that the doc fix is MACRA is a Trojan horse. You said your exact words: meaningful use is destroying the very sacred fabric of the doctor-patient relationship.
Yeah, I'm also an early adapter of EHR. I had it before the High Tech Act was passed, and I've liked my EHR. The problem is that the technology is not doing what it was proposed to do. We don't have any degree of interoperability. It's made a lot of more burdens than it's actually achieved. And despite not having the technology fixed, they rolled out legislation mandates that if we don't comply with these regulations, we're going to be financially penalized. So they put into law something that's not working like it should be. It's making us spend more time. That's taking away time from our patients. There's only so much time in a day, and it's really interfering with patient care because we have to find ways to implement this technology. It costs money. We have to train our staff, and there's just so much that we can do. And in fact, most doctors are not agreeing with the meaningful use program. We've been saying all the problems with it for the last several years. People are not listening to us. The EHR vendors, they're not willing to work together. They're all competing. They all want the business. So there's no way that we're ever going to get all of our systems to interoperate with each other. So meaningful use, it was doomed from the beginning because this competition. And then the government last year passed the macro bill, and there's a lot of things hidden in these hundreds of pages of legislation. We don't know what's all in it. Now they came out saying meaningful use is ended as we know it and something better is coming, but they do not even know how this MIPS program is going to be set into play. They don't know what the requirements they're going to cast on us.
Right.
They should have some kind of idea how it's going to play out, what the technology is capable of doing before they mandate it.
Now I'm going to play devil's advocate for a second before I lead into our next question. And that's, obviously the criticism is, well, the government spent $30 billion already, and we haven't seen the gains, and in fact, we might have even seen some steps back. I would say, and I think few people would argue, that stage one was successful in that it got the technology into healthcare facilities. I think we're at something like 95% of all U.S. hospitals with EHRs and 55 to 60% of office-based physician practices. Stage two is where we started having the headaches. Now, the savings and the gains in efficiency as well as in patient safety were not supposed to come until stage three, which hasn't started yet. Now, also, stage three was supposed to have started last year, 2015. Each stage was supposed to be 2 years. As it turned out, it's been 3 years. It was stretched out to 3 years by CMS and by subsequent legislation. Or actually, it was actually done by rulemaking, not by legislation. So the timetable has been stretched out because maybe the initial timetable was too aggressive, but the savings, the gains, were not supposed to show up till stage three. Maybe, what do you say to people who say, well, let's be patient?
You raise a great point, Neil, and in fact, one could say, based on what we've done so far, and I believe there's truth to this, that the Meaningful Use program has been successful in a number of ways. You mentioned one, that what was in the hands of early adopters, such as Linda and myself, is now basically part of the fabric of medical care. Not necessarily used as good as it could be, but at least it's there. We have a health IT literate workforce. When I first implemented an EHR back in the mid-90s, we literally had people picking up the mouse and pointing it in the air and clicking it toward their screen like a TV remote, and using the CD holder like as a coffee cup holder. I saw all that happen. Of course, none of that happens now. Our patients are also computer literate, and I can recall an interaction with an elderly woman and her adult son years and years ago who were staring intently at me using my computer in the exam room, helping to manage her, and I thought they were going to comment on, doctor, you need to look more at us and not at the screen. And I should add, my screen was triangulated, so it was shared with the patient and her son. Their comment was, when will we be able to communicate with you online? So in a sense, doctors and their use of technology in medical care are catching up with patients. You raised a great point about being patient with waiting for a certain aspect of technology use before we see the benefits, but there is something I would add to that, because I think the corollary to that question is, are Linda and I, perhaps we're addressing it differently, but being too critical now, because we really have only seen part of the program roll out. And to that I'd say, directionally, it became very clear where the program was going. And I would say, unfortunately, wish I was smarter and could have seen this from day one, because in retrospect, we could have seen this from the beginning. In my opinion, a singular set of metrics would never make sense. Where in medicine do we say the same good is achieved with what an orthopedist does than let's say an endocrinologist does? Informationalists, people like Linda and myself, I'm an internal medicine doctor, use information technology differently. And I think one of the biggest problems that became real obvious as we began to see the thresholds increase was a single set of metrics doesn't work. Secondly, and this is what we addressed in the health affairs piece, having metrics with thresholds. While CMS may have felt that was necessary to achieve program integrity and thus not give incentive dollars unless you could demonstrate you did something, actually has a dark side. And we see this with docs all the time. I'd have to even admit to being part of that dark side, which is teaching docs where the metric doesn't fit at all, gimmicks and workarounds about, I know you don't normally do this in your practice, and Linda, you alluded to this, but to pass meaningful use, it's like you have to do this whole extra workflow that's outside of what you would normally do. And in those circumstances, we could say right now, this is wrong. It's a distraction, and we need to allow for more flexibility so that people can use their technology in more appropriate ways that really helps them take care of patients.
Now, is that a symptom of the way the regulations are written, or is that a symptom of poor system design?
I think it's primarily based on the way the regulations are written. I think that the way the regulations were written, they're highly prescriptive. You know, I'm involved in many of these discussions about how to comply with the regulations, and in fact, what I still see today, years later, are very thoughtful people who should be spending their time thinking about what's the best way to use technology to better educate patients to be more engaged in care of their chronic illnesses or to take responsibility for managing their diabetes. Instead, does anyone really know how to meet subsection B of measure 8? We still don't know. The measures are written in ways that are either ill-defined or so over-defined that you have to do the equivalent of playing the children's game of Twister. You know, we have to act as a contortionist to satisfy a measure. I don't think that was the intent of Congress, and it is certainly not the intent of me going into an exam room with a patient and trying to be effective and efficient in providing good care.
So what's the future going to look like? As Linda pointed out in a MedCitizens post this week, meaningful use is not dead. It's just being, like you said, reincarnated. There was an interesting blog post this week on the CMS blog written by Andy Slavitt and by National Coordinator Dr. Karen DeSalvo, talking about giving a little more clarity as to what the future is going to look like, but still leaving out a lot of details. They did say that they're going to be rewarding providers for outcomes, which is what CMS has said they're doing with the whole Medicare program anyways over the next several years, allowing providers a little more flexibility to customize their health IT. They want to, what they say, level the technology playing field, including for startups, by switching away from maybe point-to-point interoperability and leaving it in the hands of vendors with proprietary technology, shifting it toward open APIs, and also by what they said prioritizing interoperability, because frankly that's the thing that's holding back health IT from meeting its potential right now, is the lack of interoperability. Are all these realistic? And what is the something better going to look like when we see some macro related regulations, presumably by the end of March?
Like I said in my article, I don't think we're getting something better. I think it's going to worsen the problem. The merit incentive program is going to penalize doctors who have more complicated patients with more chronic diseases. We're not going to be incentivized to take care of these patients. We're going to be incentivized to take care of patients that are already healthy. So that's one problem with the merit-based payment programs. Another thing,
well, even with the movement toward value-based purchasing, that CMS has said that they want 80% to be value-based by 2018, which they can do not just through MIPS, but also through just other mechanisms as far as how they reimburse.
Yep. So, go ahead, Linda. I'm sorry.
No, that's okay. Let's go ahead.
So I partially agree with you, Linda, that we need to be really careful with how what is termed value-based payment works, and you are correct, the devil is in the details. But I would point out that structurally, the current system, the pay-for-volume system, isn't really serving doctors or patients well either. As a country, we spend more on medical care per capita than any other country in the world, and most people would agree, doctors as well as those those who are economists, and policy wonks, that we don't get the bang for our buck that we should. So while the shift, and I would point out it is a gradual shift, within the merit-based incentive payment system, it's not like we're going from, in our fee-for-service system, now you're paid 100% for what you do, the volume of what you do, and in 2019, when the MIPS program begins, you're paid 100% based on hitting certain quality targets. It starts off at plus or minus 4%, and then it builds up to plus or minus 9% over 4 years. It makes me a little bit nervous because that's a very short time from here.
It's a very significant number.
But it's not 100%.
It's not 100%.
But it does help us to think more about value. The one thing I would add to differentiate where we are headed, which I think is directionally where we need to be, from where we are now with the Meaningful Use program. The quality measures that Linda appropriately points out we need to be careful of so that people don't select the wrong measures and get penalized based on their geography. For example, I'm in Washington, D.C. Let's say I was a doctor in Utah and I selected a smoking measure. If someone was judging me based on how many of my patients or what percentage of them smoke, as you both know, Mormons don't smoke. Most people who live in Utah are Mormons, not all. So you can be a lousy doctor, there are great doctors in Utah, but you could be a lousy doctor and have a 0.1% smoking prevalence. You could be a great doctor in Kentucky or some areas where, unfortunately, other influences besides us as doctors take effect and be penalized. But the advantage is quality measures are written in the legislation to be updated annually with the physician fee schedule. They will be based on science. They'll be based on a consensus process. Part of the legislation actually asks for people like Linda and myself and our professional organizations to become actively involved in quality measure development. Let's make them better. Let's make them fairer. Let's make them not penalize doctors for accepting care of difficult patients. The difference with meaningful use is there's a Health IT Policy Committee that comes up with an idea, might sound right, and then it gets written into regulations by a political process. So, for example,
and by the way, patients have been either not represented or underrepresented on the policy committee since the beginning.
Well, I'd say that's also true of practicing doctors. There's sometimes it makes me wonder where the reality is in some of the thinking, and I know it's very well-meaning, and I have friends on the committee who are doing a good job, or at least the best that they can. But a problem is it's short-sighted, because the way the rule is, if you come up with an idea and it gets written into regulation in the current meaningful use program, you can't change it if it doesn't work. Let's say doing something that's written into meaningful use is shown to harm patients. Do you know what the latitude that the Secretary of HHS has? If the goal of the measure is not being met, the only thing the Secretary can do is increase the threshold. The Secretary can't say, wait a second, emerging evidence has shown that we're harming patients with this, we're going to stop it. She would have to turn to rulemaking and have a whole new rulemaking process.
Which takes 18 months at the minimum, usually.
Well, yes, so while Linda's right, we need to be cautious. At least the future, to me, is based on having input from science, input from providers, from patients, from other groups on an annual basis, where we will be looking at evidence, not just political practice.
But I think we also need to be listening to input from doctors who are actually practicing in the exam room too, not just those who are directing healthcare policy.
Absolutely. I'm in complete agreement with you. And I think that the MACRA legislation, the MIPS program in particular, calls for that. They're actually calling for input from practicing providers, physicians, and that should come primarily from not just us as individuals, because our voices are small, but through us working with our professional societies, the Academy of Family Practice, the American College of Physicians, and so on and so forth, which have been attempting to be active on our behalf the entire time. I think it really will give them a much better opportunity to work on our behalf. I see patients as you do, Linda. I just happen to be home today because of the blizzards coming earlier to DC.
Okay, now,
I think
go ahead.
I think too that when they're making these policies, they rely too much on our societies and the organizations rather than practicing physicians. And a lot of doctors are not agreeing with these organizations like the AMA. In fact, the AMA now represents only 18% of doctors in this country. There was a survey done on CIRMA, which has 20% more doctors than the AMA, and 5% think these societies represent us. So we need to be getting more the practicing frontline doctors' opinions out there.
So I may have a slightly different opinion of the AMA, and I respect what you're saying, and I'm sure that statistic is correct, but I would encourage all practicing docs to work with their professional organizations, which include the AMA, but I would say in my instance, I'm an internist, the American College of Physicians. I feel that it has certainly a better handle on the pulse of practicing docs and represents us well. If we feel our professional societies are not representing our voices well, then I think it's really shame on us for not helping them to shape up, because I think they can do that job.
Now here's something interesting. MACRA, the DocFix, and MIPS, and the PQRS, Physician Quality Reporting System, and the value-based modifier that are going to make up the MIPS score, those only apply to physicians. Where do hospitals fit in this in the future of meaningful use? We don't know.
That's correct, and I think we have to wait until the first proposed rulemaking comes out the end of March to see what they're thinking about hospitals. My hope there, because MACRA does not, as you said, Neil, create a kind of a permanent life for meaningful use in the. Hopefully, I'm looking at the hashtag behind your left ear, something better. So my hope there would be that meaningful use would go away and let hospitals prove their worth by focusing on what they do best, which is demonstrating better care of patients and not how well they can check boxes.
Linda, any thoughts on that, given that you're in an office-based practice, whereas Peter's with a large health system?
Yeah, I think it's not clear for doctors in private practices either. We don't know how this is going to roll out. They haven't made the rules about it, so they put something into law, but we have no idea what's going to come out of it.
Mm-hmm. We also don't know. I mean, a lot of it comes down to enforcement, too. We're going to have a new president 1 year from 2 days ago, and we don't know what the new administration is going to do. I mean, the regulations can all be in place, but every new administration reviews every regulation that that's pending or even that had been passed in the previous administration, and also decides how they're going to enforce it. I mean, the next administration may just choose not to enforce it, which seems to be the precedent in the past. Even though it may not be legal, everybody gets away with it. So.
That's certainly a good point, Neil, and I think we need to look for that. I think one question, and we've posed this at our health system before, to think about is if the meaningful use, highly prescriptive regulations weren't there, what would you do differently when you cared for patients to provide good care? And I think in our case, it really depends on the specialty and the setting.
And I'm going to come out and say right now, don't tell me do things the way you've always done it, because the status quo is not working. We have the most expensive healthcare system in the world. Our outcomes are not very good. Medical errors have been called the third leading cause of death in the United States. Hospitals are scary places to be. They're dangerous. I don't want to hear anybody defend it because you're wrong. I'm going to say you're wrong. If you say that we have the greatest healthcare system in the world, the status quo is not acceptable.
Oh, I would agree with you.
I'm getting off my soapbox now.
Yeah, no. I would agree with you on that, but I think that there are so many talented and caring people within our health system that we need to enable them and unleash their professionalism and talent rather than by putting together a very well-meaning program that unintentionally restricted, I think, their power to do good with technology. And, again, that's a statement I make in retrospect. I think the Meaningful Use Program has done a lot of good, but I think that it is time for it to dramatically change. I'm looking over your left ear again, into something better that essentially gets as much out of the way as possible to allow for good, well-trained people to do things differently but better.
Yeah,
All
I
right.
agree with you as well. I just think it's the wrong people trying to change the healthcare system in the wrong way.
So administrators and bureaucrats rather than
Correct.
the front lines.
Correct.
Okay. All right. We have been on for half an hour. We don't necessarily have to go off the air in exactly half an hour, but I'd like to wrap things up in the next few minutes. So as we do every week on MedHeads, I ask our guests, or the host asks our guests, to discuss to you, the most significant other story, the most interesting other story in healthcare of the week. Let's start with Linda.
Yeah, I've seen stories now about the Zika virus. It's spreading in South America and Africa. The CDC issued a travel warning for pregnant women because it is causing microcephaly in pregnant women. And I saw an interesting article this week that it's also leading to Guillain-Barré syndrome in adults, and that can be a very devastating disease. I think we learned a lot of lessons from Ebola, and we really need to get on top of this before we have any more serious issue with it.
It's a potential pandemic.
Correct.
And I would agree, in our medical news, that probably is the most newsworthy. I think from a health IT perspective, and in fact, I spent the morning on online discussions with colleagues about what we do with our health IT response to Ebola, and do we now take that away and put in kind of the same level of alerts on the Zika virus. And really what we talked about was, no, let's do, again, pointing to your left ear, or over your left ear, Neil, something better. We reacted very quickly to Ebola. What we really need to think about is a better way of approaching this unfortunately rapidly emerging global threat of infectious agents, so that we educate doctors and patients well, and that at different areas of input, that we provide people with the right information when necessary, immediate quarantine or biohazard containment. So I think health IT could help to resolve this. To me, the most important health IT article that came out this week was the culmination of the Senate Health Committee's work over, really, it's just about the past year, 11 months since they've been holding hearings on health IT to make it more effective. They released draft legislation a day or two ago with a tentative title, "To Improve Federal Requirements Relating to the Development and Use of EHR Technology." They touch on a number of topic areas in the discussion draft of legislation, including
interoperability, which has been a
interoperability, usability, user-centered design. But the very first item, number 1A, is one that has been something I've been focused on from the very beginning of my health IT journey, which is reductions in burden. And I think Linda maybe spoke more eloquently about this than I did. Health IT in medicine, unfortunately, works very differently than IT in healthcare. I would say that nobody, including people who are
that's an interesting
believers,
point. That's an interesting distinction right there.
absolutely. I think everywhere else in industry, we see IT, just by the way it's implemented, reducing burden and helping the system to operate better and more effectively and more efficiently. In healthcare, because it's a very complex ecosystem with different, I would say, different definitions of what constitutes efficiency, whether you're a provider like Linda or me, or whether you're a payer, we look at efficiently differently. But the Senate Health Committee got it. I'm delighted that they were willing to see, and in fact, the first sentence, they said that it is not possible for doctors and hospitals to use health IT to improve the quality of care to patients if the first thing they face are unending and even growing burdens in the practice of medicine. So first thing is figure out how to reduce burdens so that very well-meaning people, Linda and myself, I would include both of us in there, can focus more of our time on doing the right thing for patients. So I applaud the Senate Health Committee.
All right. My story of the week is one that I wrote on Wednesday. It was based on an article that appeared Wednesday in the New England Journal of Medicine, written by Dr. Ken Mandel from Boston Children's Hospital and his colleague Zach Cohane at Harvard Medical School, who's chairman of biomedical informatics there. And they're talking about about creating a patient-driven health information economy. In other words, interoperability should be in the hands of the patients, not in the hands of the vendors and the uh, and the institutions that silo all these medical records. It's an interesting concept. It's one that's been bandied about before. Personal health records being the vehicle for controlling records, and as we know, that personal health records have not caught on any wide scale anywhere in the United States, except within closed environments, such as within, say, an organization like Kaiser Permanente, or to the user of a of specific vendors. But you start getting outside of those environments, and there is no interoperability. And they say, well, the technology is there because the EHRs are now in place. Let's make this happen. Now, interestingly, in the wake of this being published, it was password protected. The story was password protected and restricted to New England Journal subscribers until the for, Society for Participatory Medicine, I think led by Dave DeBronkart, who led that effort, made a couple of calls or made a couple of tweets and directly contacted Ken Mandel, who then contacted the publishers at the New England Journal, and they are now making this article freely available because they want consumers to read it and understand it. So that's kind of cool.
Fascinating story, and I would add that based on ONC's definition of information blocking, which is another big topic, that when you add a cost to get at information, that is defined in their minds as information blocking. So I happen to disagree with that, but anyway, it's interesting to see that they unintentionally put something out there that was indeed guilty of their own definition of information blocking. I think it's a great story. It's interesting, and I think it also gets at there are many different perspectives in what has to be made interoperable. I hold a very contrary opinion to many of my colleagues on the importance of interoperability, in that I think it's been not patient-driven and not doctor-driven. I think it's been developer-driven thus far, because the focus has been on interoperability of discrete data.
Right. I agree with that.
And I would say, as a practicing doctor, the most important thing I share with other colleagues in improving care of patients is far more related to the narrative, far more looking at what did you see, what did you think, what were your plans. And at this stage of limited interoperability, what I get back as, quote, interoperable is unreadable. It's like a set of data blobs mandated by those who scripted interoperability requirements. Frankly, I rather say, if I could delete those, and I can't, forget that, don't read them. Would you send me a fax of your note so I can actually read it and understand it? And I think interoperability is not just moving data atoms back and forth. It is sharing information which allows us to translate that into wisdom. Otherwise, we're just kind of cluttering up the airwaves with data atoms that I'm sure developers might love because they can feed apps with that data, but I don't see it necessarily helping our patients.
Okay.
Yeah, I agree with Peter there. We see so much in the medical record, it becomes hard to read, and we're not able to extract the data that we do need to take care of the patient.
Okay. Well, thanks very much. We've gone over our time, although we're not really on anybody's schedule. We just try to keep it to a half an hour. But I think it was worthwhile because I think this was a very lively, exciting discussion. I want to see people tweet their ideas with the hashtag something better for how you would fix meaningful use or replace meaningful use. I want to thank our guests, Dr. Peter Basch of MedStar Health and Dr. Linda Girgis, private practice family physician in New Jersey. Both of you, please stay safe and warm this weekend. Stay off the road if you have to. And everybody watching on the East Coast, same goes to you. Have a great weekend.
You
Thank
too.
you very
Thank you so
much.
much.